Kettering Health Network first began the Transcatheter Aortic Valve Replacement, or TAVR, in 2015 at Kettering Medical Center as part of the Structural Heart Program. To date, the Structural Heart Program is approaching nearly 100 procedures, the most performed by any hospital in the region. TAVR is a minimally invasive procedure to replace a patient's aortic valve. Candidates for this procedure are typically at higher risk for conventional open heart valve surgery. TAVR is less stressful on the patient, resulting in faster recovery times and with the same survivability rate as conventional surgery. At Kettering Health Network, we rely on a cross-functional team with a multidisciplinary approach for patient selection and replacement of the valve. One of the benefits of having the procedure at Kettering Medical Center is that the entire TAVR team and treatment process is encompassed under one roof. From diagnosis, imaging, physician consultation, surgery, and recovery, the TAVR team at Kettering Health Network coordinates and guides the patient through every process, all in one location. The cross-functional TAVR team consists of the interventional cardiologists, the cardiovascular surgeon, the imaging team and echocardiographer, the operating room and cath lab team, the anesthesiologist, and the TAVR coordinator. Each member works together throughout the process to determine the best approach for the patient. When identifying a possible patient, the appropriate characteristics must be identified in patients with severe, symptomatic native aortic valve stenosis. It is important to remember that TAVR patients can present with varying characteristics. This may include dyspnea or decreased exercise, heart failure, angina, syncope, and presyncope. Patients with severe aortic stenosis typically have an aortic valve area less than 1 centimeter squared. Once a patient has been identified as a possible candidate and is referred to the TAVR team at Kettering Medical Center, a thorough evaluation is conducted to determine whether or not the patient is a candidate. The TAVR procedure can be performed with one of 3 approaches: transfemoral, transapical, or transaortic. The TAVR team will determine the best approach for each individual patient. The TAVR team will first confirm the diagnosis of severe symptomatic native aortic stenosis with evaluations by at least 2 cardiac surgeons and 1 interventional cardiologist to verify that the patient meets the indications for TAVR. The patient will receive multiple diagnostic tests, including heart catheterization, CTA of the chest and abdomen, lab work, pulmonary function tests, frailty study, and transesophageal echocardiography. The entire evaluation and patient screening process is a collaborative effort with the patient's family, the TAVR team, and the patient's primary cardiologist. The final treatment plan is coordinated by a structural heart nurse practitioner who facilitates all providers to determine the best approach possible for the patient. No decision is made without the consent and involvement of every member, most importantly, the patient. On the day of surgery, the patient is prepped for the roughly 45-minute to 1-hour procedure and placed under anesthesia. The access point is cleaned and the catheter is prepared. Using a live X-ray, the cardiovascular surgeon inserts the catheter through the femoral artery, placing a sheath at the entrance to the artery. The surgeon will then guide a specialized balloon catheter through the sheath to the aortic valve. Once the catheter reaches the aortic valve, the balloon is inflated to open the calcified valve. During this time, the heartbeat will be temporarily sped up to stabilize the heart. The balloon is deflated and pulled back from the aortic valve. It's at this point in the procedure that the new heart valve is crimped onto a catheter for easier insertion through the sheath. The valve is then inserted into the artery and placed within the leaflets of the diseased aortic valve. The balloon is once again inflated with fluid, expanding the new valve in the location of the diseased leaflets. Once again, during this time, the heartbeat will be temporarily sped up to stabilize the heart. The balloon is deflated, leaving the new valve in place. The new valve is designed to take effect immediately after insertion and is confirmed through an echocardiogram before the catheter is removed. The sheath is then removed and the femoral entry point is closed. Following the procedure, the TAVR team will continue to monitor the patient's progress, including follow-up echocardiograms and office consultations with the team. The patient will be returned to their primary cardiologist for regular follow-up appointments relating to their general cardiac care.